Hello, everybody, and welcome to MAP 50, Introduction to Medical Administrative Careers, and Chapter 1, and what I like to call the Monday morning message. The reason that I like to call that is because typically our weeks start on a Monday, and if you're, like me, if I've got some kind of a video or a lecture or something of that nature, then I tend to, kind of get that out of the way first part of the week, and then do some of my readings throughout the week and try to, correspond what maybe my professor had shared with me on Monday and correspond my readings to that and in order to do any homework or anything like that. So anyway, I call it the Monday morning message because the weeks start on Monday, especially during the summer session like this. So the first chapter, we've got a lot of key terms in this chapter, key terms revolving around the different types of providers that there are, different types of specialties, and then kind of what today's healthcare environment looks like. So if you think about what healthcare looked like maybe 50 or 60 years ago, today it's definitely a different model, okay? Things have changed fairly drastically in a fairly short period of time. And things change almost on a daily basis in this profession. Something changes, whether that's a new medication or a new treatment therapy, whatever the case is, there's always changes going on. And it's important that if you work in this profession, that you are aware of these changes, okay? So what I'm going to do is I'm going to skip these first few slides because they just have the key terms on it. Let me get into kind of breaking down more of what these key terms actually look like. So when we look at slide 9, it says varying backgrounds of healthcare professionals. There are varying backgrounds. My particular career started 25 years ago as an X-ray technician. I received my associate's degree in that, and that kind of evolved into becoming a medical assistant. Because what I had found being in practice was I had a real interest in family practice. And practices that I worked in, we did do x-rays. We took films on site, but there was much more medical assisting work involved on a regular routine basis. Things like drawing blood, giving injections, rooming patients, getting their vital signs, performing a lot of the testing on site, like urinalysis and glucometers and that type of thing. And I quickly kind of gravitated more toward the medical assisting side. Okay, so my background started clinically. I started as a clinical person, where I was utilizing skills in the back office, what we call back office. Front office skills are administrative skills, which I will preface that with, as the medical assistant program director here at MiraCosta, I always tell my MAs that about 70% of our job is actually administrative in nature. We're always doing paperwork, referrals, prior authorizations for medications. We're documenting all of our patient interactions, getting refill requests and phoning those in or faxing those in. That's all administrative work. We're not actually putting our hands on patients probably 70% of the time. So what I like to say is that a good multi-skilled healthcare professional has clinical aspects and clinical skills, but also understands the administrative part. In my career, I also transitioned from being the clinical person to going back to school and receiving two additional degrees in healthcare administration. As I got older, I got really interested in the business side of healthcare and how the business is run, okay? So there's different varying backgrounds, and when we talk about things like the clinical side, the RNs, medical assistants, imaging technicians, phlebotomists, that's all kind of on the clinical realm. And then when we get into the administrative part, there are, different varying levels of supervision, administration, risk management, different professionals at all different levels, going all the way up to the CEO and the CFO and all of that. Okay. So practices now compared to maybe 50 or 60 years ago have definitely evolved. And some might say for the better, and some may say not for the better. Sole proprietorship, this means that a physician practices on their own. Okay, so they incur all the risks and liability. So that may be one provider, right? One provider that's got their own office, they're the only one there. It's very hard to run a practice that way. One of the things that I tell students all the time is for every one physician, it usually requires anywhere from probably 2 to 4 additional people to help that provider run the business, to do the administrative things. This gets very costly. So because of the administrative burden and cost, you don't see a lot of these sole proprietorships. As a matter of fact, you don't see a lot of just private practices, even practices that have more than one provider, but those providers own the practice. You don't see that very common anymore because the cost is so exorbitant now to do something like that. When you have even 3 or 4 providers, but for each 3 or 4 people, if you had 4 people and maybe you had 3 people that had to work in order to make that doctor's office function, each doctor had to have 3 people. Well, 3 times 4 is 12, so you have 12 additional people. And those 12 people aren't making any money. The doctor gets paid for the services provided, but I don't get paid for what I've provided, meaning the insurance company doesn't reimburse me. A patient doesn't pay me to do what I've done. They pay the doctor, and then the doctor has to divvy out all that money and is responsible for that. That is a very tough position to be in financially these days. So what you end up seeing is a lot of providers that are now a part of managed care organizations. Kaiser, that's probably one of the bigger ones, right? And if you think about that, the doctors and everybody there are employees of Kaiser, and Kaiser handles all of the administrative burden of this, right? So it's a little bit more, from a physician's perspective, it's just more cost effective and less responsibility that the physician has if they've relinquished that over to Kaiser. So to reiterate, you have the sole proprietorship, one doctor, solo practice, taking care of everything. Then you might have this group practice where there's a group or more than one physician who are sharing the expenses of running the practice. Okay. And that would, obviously they share in the costs and then they share in the liability risk, right? Okay. Professional corporation. This might be something such as maybe a Kaiser. Then there's physician-owned organizations, which might be something like the Cleveland Clinic in Cleveland, Ohio. That's a physician-owned entity, and it's one of the largest in the country. But the physicians are salaried. They own in a group. They own the Cleveland Clinic, but they receive a salary. They share in all the costs. They hire in administrators in order to do all of the administrative type of work, and then the physicians determine what types of services are going to be provided by their group, okay, by that clinic, the Cleveland Clinic, okay. Let's see. Retail clinic. This one kind of like maybe urgent care, okay. If you think about an urgent care, it says typically takes cash only, operates in a retail setting where you might find a lot of urgent cares. Walmart has some minute clinics and that type of thing. Those are good for fairly quick, easy, uncomplicated problems for patients. These are typically found in retail settings. Oftentimes they take. Let's go back on that. They don't often take cash. The majority of these places actually do take insurance payments, but some places do only take cash. And again, it's for minor problems, not very complex healthcare issues. This one is kind of interesting, and I do have a little bit of experience with this, a concierge clinic or a concierge, maybe private doctor, sole proprietor. This has kind of taken a little bit of a hold here recently because of the high cost of running a practice or having a practice, and the administrative burden in particular that's required. Some doctors have decided to kind of branch out their own and do this, what they've termed as concierge medicine, meaning that the doctor typically limits the number of patients that they see. They usually only see these patients on a cash pay basis. And oftentimes, one of the requirements for something like this is that you may pay like a one-time annual fee, every January or every February or something. And maybe that's $3,000, $3,500, $4,000, whatever the case is, whatever the charge is. And that fee covers you for the whole year in order to see this particular doctor. And in exchange for that, the doctor typically gives you greater access to them, more ease in scheduling because they're seeing less people, and they're kind of almost becoming like your own private doctor that you have greater access to. This works for people that maybe have the finances, obviously, to do something like this, right? If you had to, plop down $3,500 every January, you would have to have $3,500 in your bank account, right? So this works for people that have money, that have finances and resources to be able to do this. So it doesn't work for everybody, all right? And that fee doesn't cover things like if the doctor is requesting you to go get an x-ray or something like that. You're going to have to pay for that out of pocket. They're going to have to send you to a standalone facility that does imaging, and you're probably going to pay for that out of pocket. Or if you do have insurance, insurance might pay for that. But typically in the concierge realm, the doctor doesn't take insurance. They only take cash. So all of the fees to see that doctor are taken care of on a cash pay basis. Okay. Obviously, we have healthcare settings in all different places, so I don't really think this offers us very much. What about the types of physicians, though, in these different and varying places around the country, right? Family practice. Probably, I'm a family practice guy. I've spent most of my career in family practice. I like family practice on a personal level because family practice is where you build relationships with patients. You build relationships with people, okay? Family practice also typically sees a wide variety of patients from all different walks of life, all different socioeconomic backgrounds, all different religious backgrounds, ethnic backgrounds. It is a hodgepodge of human activity, right? And different elements that make us who we are, right? I enjoy that. And in family practice, we treat virtually every type of disease. We see patients from cradle to grave in family practice, and we also see everything from routine preventative medicine and immunizations to end-of-life issues, cancers, and we see people up to the last day of their life. I like that because it's variety. That's what I like. However, we have a lot of specialists, right? Almost everything is broken down into specialties anymore. Family practice is actually a specialty. It's a special branch of medicine, okay? So we have other providers, right? Pediatricians and internists. These are kind of like your general practitioners, right? Your family practice, pediatrician that deals with issues for younger people, typically 17 and younger. An internist is an internal medicine doctor. They deal with a lot of the types of issues that family practitioners deal with. So these are kind of like your general practitioners, okay? Education in the U.S. for, providers, right? And there's really 3 different types of providers. And I'm not sure that everybody always understands this. But in the United States, we have basically 3 different types of providers, right? We have a medical doctor, an MD, or a DO, a doctor of osteopathic medicine, which is a doctor who is trained in the same things that a medical doctor is trained in, but also get some extra additional training in osteopathic medicine, which is kind of like a whole body approach to medicine. I always liken DOs, which I've typically worked for DOs during my career. I see a DO as a patient. I see a DO. DOs are kind of trained in this more holistic approach where it's a combination of Western and Eastern medicine that creates this whole body approach to healthcare. So you have an MD and a DO. Those are your basic two types of doctors. Then you have a physician's assistant. A PA is a provider of medicine. Okay? A PA is not an MA. A medical assistant can't treat, diagnose, can't do that type of stuff. A PA is a physician's assistant. They can treat and diagnose patients independently. Okay? A PA, if you've ever seen a PA, after you see a PA, the PA doesn't run out of the room after they get all the information on you and then go to the doctor and say, hey, doctor, this is what I think is going on. What do you think? Do you concur? That's not how it works. A PA treats and diagnoses independently. The only thing a PA cannot do is they cannot practice without a supervising physician, meaning that a PA cannot open their own clinic. They can't have their own private practice. They have to have a supervising physician on staff. But again, that doesn't mean that supervising physician makes all the final decisions. The PA can treat independently, okay? So that's the second type of provider. Then the third type of provider is a nurse practitioner. And a nurse practitioner, different than a PA, can practice independently. A nurse practitioner is typically, in my experience, is usually the most educated of anybody in the office, because a nurse practitioner is somebody who became a bachelor's in nursing, then got their master's in nursing, and then was accepted into a nurse practitioner program which is almost like getting a doctorate in nursing, basically, where they get 3 or 4 more years of education and do a residency and then become a provider where they're treating and diagnosing just like a doctor, MD, DO, or a PA, a nurse practitioner. A true story, in my last practice, we had hired a nurse practitioner. She had a 15-year cardiac background, right? Worked for a cardiologist in Denver, the largest cardiology group in Denver, and we hired her. What ended up happening was, when in family practice, we have a lot of patients that have heart-related issues, cardiac-related issues. And we started the doctors, we had 2 doctors on our staff. Those 2 doctors started referring all of their cardiac patients to go see Mary, the nurse practitioner. You need to be seeing her for this issue. And the patients originally were like, well, why would I see the nurse? And we're like, she's a nurse practitioner. She's a provider. She has 15 years of experience in cardiac medicine. She's the expert, not me, the medical doctor. I'm not the cardiac expert in this office. She's the cardiac expert. And invariably, what would happen is patients would go and see Mary and would always come back out and say, you know what, I'm glad the doctor suggested that. Mary really knows what she's doing. But yeah, she's the expert in this field, okay? Just because somebody's a doctor doesn't make them an expert in every single branch of medicine. That's why they specialize. That's why doctors specialize in something. They become experts in that particular type of medicine, okay? So anyway, this is kind of how this works, right? Most providers end up getting a 4-year undergrad degree and then typically do 3 or 4 more years of medical school, and then usually anywhere from 3 to 7 years of a residency where they're learning more about their specialty that they've chosen, and they're practicing and applying their medical knowledge in that residency to become that expert in that field, okay? The majority of doctors then become board certified in that specialty, all right? Usually the length of the residency, honestly, kind of depends on the school that that you're going to, that's helping to provide the residency to you, and the type of medicine that you're going into. I would always look at it this way: would you rather have a family doctor who goes through 7 years of a residency to be a great family doctor, and the brain surgeon only go through 2 years of residency? I think you'd probably want it flipped around, right? Somebody that's doing brain surgery, you'd want them to have as much experience and as much exposure to brain surgery as possible. So usually, kind of the higher risk types of fields in medicine oftentimes require a greater length in residency. Okay, and I think that only makes sense, right? All right, so different types of specialties, other than like family practice, pediatrician, that type of thing. We've got allergists, okay, cardiologists, which we've already mentioned, dermatologists, specialists in skin issues, gastroenterology. Okay, these are the people that deal with things like your intestines and your internal organs related to just lost my train of thought. But related to the things, the digestive system, right? A gastroenterologist, a gerontologist, somebody that treats conditions of aging, gynecologist, female issues, obstetrician, female issues when you're pregnant. Some doctors become an OB, some become a GYN, some become an OB-GYN, where they're doing both types, right? Female-related issues plus their pregnancies, okay? Hematologist is somebody who deals in disorders of the blood, things like leukemia, for example, okay? So you have all of these different types of specialists, okay? Kidney doctors, the liver doctors, neurologists that deal with nervous system disorders, okay? Oncology, which is the study of cancer, so an oncologist is a cancer doctor, so on and so forth. I think you guys get that, right? So become familiar maybe a little bit with these different types of specialties. If you recognize one in this list and you've said, oh, I've heard that, but I don't know what they do, get a little definition right there. All right. All right, so what is the role of the office manager? That's very important, right? An office manager or practice manager, they basically manage the day-to-day functions of the office, oftentimes dealing with a lot of the financial issues, things related to insurance, but they're also, doing things related to employment, employment law, that type of stuff. They're overseeing, hopefully, the smooth functioning of an office, okay? Usually to become an office manager or practice manager, honestly, usually you're going to have to probably get an advanced degree in healthcare administration, probably have to have some experience in accounts payable and accounts receivable, managing people, supervision experience, that type of thing, okay? But that can vary from organization to organization. It depends, right? I would probably say that the higher up the healthcare food chain you go, meaning like if the bigger the organization, probably the more requirements they're going to have on you in order to become a practice manager or an office manager or some kind of administrator. If you're trying to get experience fairly quickly or are new to the profession, then it might be something like a smaller practice, maybe a private practice if you can find one, because they're hard to find anymore, but maybe a smaller organization and something that maybe you work into, right? So you might start out maybe on the clinical side, like myself, and then work into, as you continue on in your career, work into that type of supervisory position, okay? What are some traits of a good medical office manager? These are traits, honestly, for almost everything in medicine, right? Communication skills, very important, often overlooked. Organizational skills, leadership skills, okay? What are some things that you can do once you get into this profession? Continuing education opportunities. Some of our certifications require that we do this. In order to be a doctor, you're required to perform so many hours of CME every year, continuing medical education. So you can't just rely on, oh, I went to medical school 20 years ago, so I know everything now. When I started this presentation, I said medicine changes on a daily basis. How do doctors stay current? They have to do continuing medical education. So they attend things like seminars, conferences, have membership in professional organizations. I do all three of these things because of the certifications that I hold. I do this as an educator. I have to do seminars and conferences and continue to learn new things in order to stay current with the state of education. Okay. Matter of fact, at the end of this month, I will be at an online educators conference in Long Beach, and that's going to, and this is 2022, by the way. That particular conference is something that hopefully I will get some information out of it that I do not know and can be able to apply it to some of my online coursework. I always say that I learn something new every single day. I don't care what it is. I don't even care if I'm sitting at home doing nothing but watching TV. I'll guarantee you I probably learned something that I didn't know when I woke up this morning. Okay? So I'm always looking for those opportunities, and that's part of professional growth most of the time. In this profession, you're going to be required to do some of these things. Okay? So what does the future of healthcare kind of look like, or healthcare management? More services provided in the ambulatory care setting, outpatient, okay? And we're already seeing that, okay? You're already seeing things like standalone imaging facilities. You're seeing more memory care facilities. You're versus what we used to do for people that had Alzheimer's or dementia, something like that. We would admit them into a hospital. Now we have, private centers for people to go to. We're seeing more of a move away from the hospital and a move to ambulatory care settings or outpatient focus. Okay. Of course, we're always concerned about cost. That's always going to be an issue. So we're always focused on ways to reduce cost or provide, lower cost services. More healthcare needed for the growing aging population. This is why I got into this profession 25 years ago. The majority of the people on this planet right now are baby boomers, those born between 1946 and 1964. That is the majority of the human population on the planet. These people are aging, right? So when you think about that, if you were born in 1946, then you would be what, 70, going on 76 years old this year? Okay. So the majority of people are 76 years old, in between 76 years old and 58 years old. That's the majority, okay? I almost fall into that category, all right? Let's see, continued decrease in reimbursements. Yes, because the high cost of things, we see movements on all the time from insurance companies in particular that are trying to decrease the amount of reimbursement they're giving to providers. Okay, so issues related to access to care, right? We see that a lot of times. We don't live in a country that everybody has the same type of access to medical services, and that's unfortunate. But that is the system that we currently work under. So we have many issues related to that type of thing. So what do we need? We have a high demand for people that can help to bring about change and to help manage organizations that are currently in existence to continue to be in existence. Okay, so that covers chapter 1. This was a little bit longer presentation than I wanted it to be, but chapter 1, read your text, look at the PowerPoint, right? You will have a exam that's going to cover, I think your first exam covers chapters 1 through 5. So there will be some questions that on that first exam that you take that will be from this particular chapter. So become familiar with it. And I hope this provided you with a little bit of an overview of what some of the things we're going to be talking about coming up in the future. All right. Thank you. And I'll see you next week for another Monday Morning Message.